So I'm Dr. Becky Lynn, and I run Evora Women's Health. We are a concierge women's health practice dealing with women at midlife and beyond. We provide everything a woman needs in one supportive space. And today we're talking with Dr. Michael Twyman, who is a cardiologist. And I have to say that heart health is super, super important to my patients, especially as they get into their 40s and 50s. So I hope all of you out there are listening, watching, learning, and at the end, we will definitely be taking questions for Dr. Twyman. So do you want to give us a little introduction?
Sure. Well, thank you for having me on your channel tonight. So I'm Dr. Michael Twyman. I'm board certified cardiologist, did all my training at St. Louis University, and my practice, Apollo Cardiology, is currently in downtown Clayton, but got some big news coming up soon that we're going to be expanding spaces. So adding more toys and things to repair people's mitochondria, hopefully a little bit later this summer. So I focus on heart attack and stroke prevention, and women's health is something that I've been helping patients, improve their health for the past 8 years, and many patients, who have issues with their hormones and they're going through menopausal changes. One of the things they may notice that their cholesterol numbers are creeping up, and then they get referred into my office to kind of figure out what is their risk.
Yeah, so I have to ask, where are you moving to? Are you allowed to say?
I signed the lease last week, so it's not too far away. So it's beyond Brentwood, across from Galleria. So 4 times as much space, but a lot more interesting toys I can add to the office, and then some mito hacks I'll have there pretty soon.
That is great. So what would you tell midlife women about heart health? What sort of, recommendations would you have for them?
First off is, test, don't guess. I mean, many women start getting mammograms at age 40 to look, do they have any early evidence of breast cancer? And heart disease really shouldn't be any different. Unfortunately, too many people wait until they fail a stress test or they have a heart attack to know that they actually have disease. You don't really want to wait until you have symptoms, so go looking earlier. And your labs, might point you in the right direction, but you actually want to go looking at the arteries. And there are many non-invasive tests that can look at the arteries. 2 of the ones I routinely recommend are a CT coronary calcium score, which is a low-dose radiation scan of your heart arteries. You're only supposed to have calcium in your bones and teeth. It's not supposed to be there in your arteries. So if you have calcium in the arteries, you have plaque building up in the arteries in your heart. And then there's an ultrasound test you can do of your carotid arteries that looks for inflammation of the walls of the artery, as well as soft plaque starting to build up there. And if your arteries are developing plaque here, you're likely developing plaque somewhere else in your 60,000 miles of blood vessels.
Right. So at what age would you begin the screening?
The carotid scan depends a little bit more on kind of family history. I mean, maybe as early as 30 years old in the right population. The CT coronary calcium score is typically 40-ish is about the earliest I'd really start considering it.
Yeah. And then, so let's say somebody came in and had these tests done. Give us a little idea of how you do it, how long it takes, what to expect.
So CT coronary calcium score is done at a few different centers in the St. Louis area. The test is usually between $100 and $200. Takes 5 minutes. There's no real prep for it other than they do ask you to fast, but there's no IV, there's no special medicines you have to take beforehand. And you hold your breath for about 10 seconds and you're in and out of the scanner. A perfect score is 0. So I usually tell people this is the only test you want to, quote, get a 0 on. If your score is higher than 0, it means you do have some plaque building up. Basically 1 to 100 is kind of that intermediate risk, 100 to 400 is high risk, and then you start getting into 400, over 1,000, you're getting to be very high risk. So it is kind of graded. Most women in their 40s really should have a score of 0. If they don't, then you got to do the blood markers to figure out, do they inherit lipoprotein A or something else that would put them at an earlier risk of developing vascular disease. In the carotid scan, it's 5-10 minute test, or put some gel in the neck, take some pictures of the heart arteries. And then we can tell you essentially how old your arteries are. So if you're biologically 40 years old, but your arteries are 60 years old, you're essentially 60 years old.
Right. So then let's say you did have this coronary calcium score. So definitely I'm not a cardiologist. So is there a way to lower that calcium, or is it really just a surrogate marker for heart disease? And then you really would just focus on diet and exercise?
It's a great question. So it kind of goes both ways. The first goal is to figure out, is the plaque present, and then what's potentially putting the plaque there in the first place. And that's usually with blood work and a good history. But usually the goal is just don't have events, don't have a heart attack, don't have a stroke. 6 out of 10 people that do this study are going to have an abnormal score, but that doesn't mean you're automatically going to have a heart attack. There's soft plaque, which is more likely to kind of rupture and cause a heart attack, and there's hard calcified plaque, which is not likely to. Might cause symptoms when you're exercising. It's usually kind of a later stage finding, but there's things that can be done that help kind of stabilize that plaque. And in some cases, the plaque will actually regress or get smaller, but the first goal is that it doesn't keep creeping up. If you have an abnormal score and you did nothing, the calcium score test typically going to keep cranking up about 20% a year. So first goal is just find it, try to arrest it, and then ultimately you might see it regressing. But you typically will see it regressing in the soft plaque first.
So, so what do you recommend to get people to help it regress? What do you tell them to do?
Get the correct test first. I mean, cholesterol is needed by every cell in your body. It wasn't put into you to give you a heart attack, but if the cholesterol particles that can ferry the cholesterol through the system get damaged and they get retained in your arteries, then the plaque's going to keep building up, and it's like a little abscess or pimple on the walls of the artery. So, vascular disease is generally a combination of inflammation, oxidation, and vascular immune dysfunction. So your immune system is ramped up. So you got to figure out why you're inflamed. Your immune system should come on when you have an infection, or you sprain your ankle. You want your, blood to go to your ankle, get all the healing factors there, and then go away. So you just make sure you're not rusting from the inside. And there's blood tests you can do to kind of tell you where you're at on that stage.
Yeah, and we see a lot of inflammation, and I know that obesity, people who are obese, have a higher level of inflammation going on, and I know that people who are obese also have a higher risk for heart disease and stroke. And I don't know if that's the direct link. There's probably about a zillion other links and things that are going on. But I've recently taken a little bit of an interest in this inflammation because there are really good foods you can eat that are kind of anti-inflammatory. So we have dietitians here who can help you choose those foods, talk about the benefits of certain foods. I know berries are very anti-inflammatory. I can't look at a blueberry the same way now without feeling like I should be eating that blueberry. But yeah, inflammation, we like you said, we think of it as sort of a good thing. It helps your body heal, but it can also cause some problems, definitely.
Especially if it's chronic. And obesity is one of the things that it's complicated. It's much more complicated than calories in, calories out. But obesity also depends on where you're carrying that extra, fat. If it tends to be in your kind of gut area, that tends to be more inflammatory. So there's at least one school of thought that people become more fat because that's where you store most of your toxins. So you're doing that as an adaptive response. And so sometimes when people start really losing a lot of fat, their inflammatory markers are going up as they're liberating those toxins back into the bloodstream.
Right. That's interesting. Very interesting. What are the symptoms that midlife women should be looking out for?
So, the classic, an elephant on your chest sensation isn't always present in women. If you have that sensation, you definitely still need to go get it checked out. But women sometimes present a little bit differently. They may just be more short of breath, especially with activity. So, they're going upstairs or, they're at the gym and they just can't do what they used to do. They just feel off, or they feel a uncomfortable sensation in their chest, neck, back area that goes away when they stop the activity. So that's kind of the classic angina, is that you outstrip the body's ability to provide nutrients and oxygen to the tissue, and the body starts complaining with some symptom. You stop the activity, in a couple of minutes the symptoms go away. That's pretty classic angina, but people don't always have the same symptoms. So if something new pops up, definitely talk to your healthcare provider to try to figure out if there's something going on. I mean, it's not common that somebody has 0 risk factors, no family history, and just out of the blue shows up with a heart attack. Can happen. It's more kind of spontaneous coronary artery dissections, which are rare. But typically somebody's going to know they have a strong family history, or their labs have been abnormal for 10 years. You're probably in a little bit higher risk category, so you just got to listen to your body a little bit more.
Yeah, and it definitely. I mean, and I think when you say like family history, I think it's important to realize that part of that is, somebody having a heart attack at a young age, very young age. And if there's more than that, throw it out there, because that's what I think of when I think of like a strong family history of heart disease. What else would you think of besides like someone having a heart attack in their 40s or 30s?
I mean, I'll just back up a little bit. I mean, vascular disease starts with endothelial dysfunction, and that starts in your teens and 20s. So you got a good 5 to 10 years that if you find somebody's arteries not making enough nitric oxide, if you can fix that problem, they don't develop the plaque in the arteries in the first place. So atherosclerosis is a chronic disease that generally will take many years to build up. So you just got to go looking for it early. By the time you got symptoms, you're not too late to the game, but it gets a little bit harder to fully reverse it at that stage.
Yeah, I wonder why, it isn't something that everybody's doing now. I wonder, do you have any ideas like why we aren't all checking coronary calcium?
I think, the healthcare system has always been set up to do more emergency care. That's how it was set up in the 1900s, infectious disease and later trauma, and you kind of put that model together, and that works well. And we're always going to need people in the emergency rooms and ICUs to put people back together if they get broken. But the chronic disease model generally isn't best fixed in a 15, 20-minute visit. If you just see somebody and they have one symptom and you say medication, next patient, you really don't really get to the root cause of the concern. And many times it's a third-party payer. If they're not going to quote cover a test, it's almost an invisible test to the patient and the doctor, because not everybody understands that your health is your responsibility. You have to invest in your own health. Even if your insurance company doesn't want to quote cover the service, sometimes investing in your health is the best option for you.
Right. I have to echo that. That's exactly how we operate here at Evora. We're so about prevention. That's part of the reason that I left traditional medicine, because you can't do a lot of counseling and about prevention and screening and everything in a 5 to 15-minute visit. So we focus a lot here on appropriate screening tests, diet, exercise, mental health. And I feel really fortunate that we're able to do that here. And I would agree with you that the system is really set up to have somebody come in with a problem, fix the problem, and out the door. So I'm really glad that we're able to offer this to our patients in St. Louis. So.
Yeah, and like I said at the beginning, I trained at a very good university. I was well skilled and take care of critically ill people. But I, at some point during my training, got to the point of wanting to know a little bit more about, we have all these people on quote blood pressure medicines and cholesterol medicines and diabetes medicines, and they keep coming back for the same events. So there had to be something deeper. So once I got my conventional training, I did more training and kind of discovered mentors like Dr. Mark Houston. He said like there's 400 reasons plaque is building up in your arteries, and typically you're only ever looking for 5 or 10 of them. So if you don't go looking, you don't find things.
Right.
It just takes a little bit more curiosity on the patient's part and the doctor's part to really get to the root cause of things sometimes. But you're right, it's it always going to start with the foundation of lifestyle. And I usually talk about kind of 4 pillars of health. Everybody's pretty aware of nutrition and exercise, and I'm not saying they're not important, but sometimes that's underrepresented is dealing with your stress. Everybody has stress in their life, but how do you cope with it? And then sleep. Too many people put sleep on the back burner. And as you know, I'm sure you slept in hospitals for many, many nights of your career, and sleep was not a priority. You just did what you needed to do to take care of your patients. But then when you got out of training, if you keep doing that, you're going to end up being a patient sooner than later. You just break down without that sleep. And so eventually I kind of figured that out for myself, that if I was going to do this career for 30, 40 years, I could not be up at 3 o'clock in the morning taking care of broken patients. Otherwise, I'm going to be on the other side of the table someday.
Yeah, absolutely. So it's interesting that you should bring that up about stress and sleep. So I have been reading a book about brain health and how to prevent Alzheimer's disease and dementia and cognitive decline. And one of the things they talk about a lot is the importance of sleep. And as I'm reading it, I think to myself, for 20 years, I delivered babies. I got no sleep. I worked the next day. So I didn't even for some of that time, get to go home and go to sleep. And, that I feel like the longer I practice medicine, maybe we're getting more information about the importance of sleep. I mean, it's regenerative. You really, really need your sleep. And most people need, 7 to 8 hours to sort of reset everything. And even memory, I'm getting off the topic here, but I've been fascinated with all these things that I've learned about the brain. Even getting those memories to stick, part of it has to do with getting adequate sleep. And the other thing you mentioned was the stress. So one thing that we do here is we always ask about moods. We always ask, are you feeling sad? Are you feeling down? Do you feel anxious? Because, your overall health, your stress level, right? Like has everything to do with your heart. And yet in that 5-minute visit, we don't have time to ask about it. So I think mental health is health. And, you know, everyone deserves a therapist. So those are two really, really important things.
Yeah, and if you or your viewers want a really good book on sleep, Why We Sleep by Dr. Matthew Walker, that's probably the best sleep book I've read in the past 3 years.
Oh, really? Okay, I'm going to have to write that down. Or will you
Dr.
text
Walker.
after this?
Yes.
Or maybe Chloe can remember it, because, yeah, Dr. Walker, Why We Sleep. Yeah, it's fascinating, fascinating. It's very interesting. And I think, yeah, I mean, you know, we talk about prevention, and you know, for the longest time, we didn't know how, well, we still don't really know how to prevent Alzheimer's, but, you know, there are definitely things we can do. And one thing that book makes note of is that what's good for the heart is good for the brain.
100%. I mean, it's a mitochondrial story. I mean, you know, your mitochondria, the organelles in your cells, you know, they do many things, you know, but one of the big things is that they help make energy for the cell. And life is about energy. You know, the difference between being alive and dead is energy. And so how do you mind your mitochondria? Well, most of your mitochondria are in your brain and heart. And you're right. So whatever you do that helps your heart is helping your brain. And yeah, there are not great treatments for end-stage Alzheimer's. So the whole goal in Alzheimer's is prevention. And, you know, blood flow to the brain is one of the best things that helps with that. So that's where the exercise story is. You know, exercise improves brain-derived neurotrophic factor. It improves the upregulation of cytochrome C oxidase. So your mitochondria are able to make more energy. More energy, you don't have a brownout in the brain tissues then.
I love that. That's fantastic. So I just want to throw it out there. If anybody has any questions, they can type them in the comments and we'd be happy to take them. And while we're waiting to see if anybody has any questions, I just wanted to see if there was anything else that you want to say, Dr. Twyman, that you think is important for all of our listeners, viewers, watchers to know.
So I would say, you know, the CT coronary calcium score and the carotid intimal medial thickness test, those are the two best tests for people who really want to know, are they low risk or high risk of having a heart attack or stroke. But if you're going to do blood work, you know, you need to do more than the traditional cholesterol panel, because there is no such thing as good cholesterol. There's no such thing as bad cholesterol. There's just cholesterol. But there's different things called lipoproteins or particles that transport it around. And there's very inexpensive blood tests that can measure those things. But also people should really go get this test done at least once in their life, something called lipoprotein(a) or LP(a). It's very similar to LDL, but it's more of a, I'll use the microphone, it's more atherogenic and thrombogenic, so it's more likely to build plaque in your arteries, and it's more likely to cause your blood to clot. It's genetically inherited, so 20% of the population has it. And so you need to know if you have it. If you do, you know, you gotta be more aggressive with your lifestyle, because if you don't, and you have high LDL particles, high inflammation, you're that person who can be like Bob Harper, having a heart attack at a much earlier age than you should.
Right. So we do have a question here. It says, why fast for the calcium scan, and can you tell hard versus soft calcium on it?
The fasting part, I think, is more that, you know, they don't want you to have a lot of food in your stomach in case, you know, something happens, you had a reaction. There's no medicine going into you, but you're not going to have a reaction. But the thing is, they don't want you, basically throwing up, laying on your back. And then the second thing is, when you eat, blood is shunted. About 20% of your blood flow goes to your stomach. And so your heart rate tends to go up after a meal, and if your heart is beating faster, it's harder to take a quick picture of it. So that's the one reason I ask you not to eat. And then, the question is a good one, is it's really only looking at hard plaque. But wherever there's hard plaque, there's always going to be soft plaque present as well. Ballpark, it's going to be wherever there's hard plaque, that's only about 25% of it. So that's like the tip of the iceberg. There's a lot of soft plaque under that area. There are tests, using a CT scanner that you can get a look at the soft plaque. But that's called the CT coronary angiogram. That's going to require IV. That's going to require IV contrast. And typically they give you beta blockers to kind of slow your heart rate down so that the heart isn't wiggling too much when they're taking the picture of it. But that's definitely not a screening test for people. That's more for people having symptoms.
So we have a couple more questions. So what is your experience with estrogen replacement and heart health?
This is not individual medical advice, but but typically, as I mentioned earlier, is that as women head into perimenopause and menopause, their LDLs tend to increase. And their vascular risk starts approaching the same as a man. So they're 10 years generally behind a man on their cardiovascular risk. People get, rightfully concerned about breast cancer, but heart disease is extremely common in women. It's the number one thing that's still going to get you. So don't forget about your heart, if you're a woman in menopause. But estrogen is protective earlier, and in that perimenopause and shortly after menopause, estrogen is going to at least be neutral to beneficial. It's not going to be harmful. Now, the story of if you're an 80-year-old woman and you've never been on estrogen replacement and they're hammering you with estrogen, that might be problematic. But then you've had 30 years where your arteries have been aging before they put that on there. So as a cardiologist, I have no problems, working with somebody who knows what they're doing, keeping your hormone levels in optimal ranges, not a concern.
Yeah, and actually estrogen in that 50 to 59-year-old age range, or that within 10 years of your last menstrual period, can decrease the risk of heart disease. But I agree with you. You don't want to take an 80-year-old who has a plaque there and start estrogen at that point, because it increases the risk that plaque would be destabilized and break off and go cause a heart attack or a stroke. So yeah. One more question. Somebody said, what was that particle again?
It's called lipoprotein little a, or LPA.
Okay. And should patients just ask their provider to add it on when they do their cholesterol, or should they see you and so you can interpret it, or what do we do once we have results?
Yes, either way is excellent. It is a test done by LabCorp and Quest, so a traditional lab can do it, so it doesn't have to go out to a big specialty lab. And most part, even if you had to pay cash for it, I believe most times it's like $20 at most. So it's not a break the bank type of lab. And if your levels are quote normal, you never have to check it because you don't have the genetically high version. If you have high levels, somewhat debatable too, should you repeat it? Because currently there is not a pharmaceutical or even a nutraceutical agent or a lifestyle intervention that's going to make a significant difference at dramatically lowering it. Yes, estrogen replacement therapy and somewhat niacin will have an effect at lowering LPLA, but probably not to a level where it actually really reduces risk per se. And I've not yet, and I probably will never, recommend people start, estrogen replacement therapy just for lipoprotein A. If they have their menopausal symptoms and they're on it and their LPA goes down, great. But LPLA, it's the kind of the hidden risk factor that probably in the next 5-10 years, people are going to start becoming more aware of, because that's really what's giving people heart attack, strokes. It's not just traditional cholesterol.
I have not had mine checked. I might have to come see you and have you order that for me, because now I'm really curious.
Yeah.
All right. Any last minute questions? Anything else you want to? Oh, we got another one. You mentioned reasons for calcium high score would most cardiology docs know this? The calcium.
They would now. I mean, in the past couple of years, it's actually gotten into the lipid guidelines, and sometimes it's a good tiebreaker. So certain patients, if you've already had a heart attack, you've had a stroke, you got stents, you got bypass, you're high risk. And lowering lipids with prescription medications such as the statins has been shown to reduce, recurrent or recidivant, events. But if it's primary prevention, meaning you've never had an event, and you just have quote high cholesterol, you should have a conversation with your provider. Is the statin the right medication for me? And some patients, want to work more on lifestyle and nutrition. That's always the first goal. But some patients, if they get the calcium score test and their score is 0, lifestyle. The statin is really not going to lower your risk in that individual. You do a calcium score test and their score is over 400, that person really should consider a statin unless there's a strong indication that they shouldn't take it. There's another genetic marker, or they have some, they're likely to get pregnant soon. There's maybe a potential reason why they shouldn't be on the medication. But the calcium score test is a tiebreaker now, and even the traditional cardiologists are trying to utilize it for that. But I would say the one difference is sometimes that the general cardiologist, they'll just look at it and say, high risk, here's your statin. They won't always know exactly what are the best options at trying to stabilize that plaque or getting it to regress. And so that's where somebody who's done some integrative functional training has a little bit more knowledge on that part of it.
Right. Great. All right. So where can people find you again? Do you want to just throw that out again?
Sure. So, thank you for having me on your show. I'm, located in St. Louis. The current office is in downtown Clayton. My practice is Apollo Cardiology. The website's apollocardiology.com. I'm pretty active on Instagram. That's where I usually have right after the Sunday, an Instagram show, 6 o'clock Mondays all the time. This week's going to be about statins and myalgias, which is a common topic I get and questions I get asked in the office. But yeah, find me on Instagram. It's just at Dr. Twyman, and spelled DrTwyman.
Fantastic. Well, thank you so much for doing this Facebook Live for our patients, because women need to know this stuff. So we really appreciate your time.
You're very welcome. Thank you, and have a great evening.
We'll see ya.